I thought you
I just give you a quick introduction to Nava before we go through the notes. This is something that's come about within 10 years, and it's been gaining in popularity ever since. Put out by McKay, or the Servo Eye people. And there's a nasogastric tube that they've invented that when the nasogastric tube is in place properly, it can sense the electrical movement of the diaphragm. So the signal from phrenic nerve to the diaphragm can be picked up with this tube that's in the esophagus. And from that, you can see when the diaphragm is getting ready to contract because there's going to be an increase in the electrical impulse. Diaphragm's getting ready to contract. So when you take that information and feed it inside the ventilator can synchronize the brain's signal to tell the diaphragm to contract with when the breath is delivered to the patient. So I know when we were learning about mechanical ventilation, I said, oh, if you use flow-by sensitivity, it's a lot more sensitive to patient effort. Pressure sensitivity isn't as sensitive. So in your mind, you're probably thinking, no, flow-by sensitivity, that's the way to go. But once you have Nava signal, and you're looking at the Nava signal on the patient, flow-by sensitivity isn't the greatest. The best is when you're looking at the actual signal of the diaphragm. That's the best way to synchronize the patient's breath. So that's everything in a nutshell. Now we're going to go through the lecture. So Nava stands for Neurally Adjusted Ventilatory Assist. This type of ventilation is synchronized with the patient's breathing. It's better than flow-by. It's better than perfectly adjusted flow cycle off. It's better than the perfect rise time. It's even better than BiPAP ventilation. When ventilator breaths are perfectly synchronized with the patient's work of breathing, the number of days on the ventilator is reduced. So this is like the best respiratory therapist there is that can synchronize the ventilator breaths perfectly with patient effort. So Nava can be used with or without mechanical ventilation so that signal can still be fed back to the ventilator from that special NG tube. I'll tell you the name of it in a minute. And then the ventilator can deliver non-invasive ventilation or BiPAP to the babies. So first, a special nasogastric tube needs to be inserted in the stomach. And this NG tube, or this catheter, is called the electrical activity of the diaphragm catheter, and it's abbreviated EDI. So that's where they got the name of the catheter, EDI. Electrical, so E from electrical, activity of the diaphragm, so EDI catheter. The EDI catheter has several electrodes that detect electrical activity. The electrical activity of the diaphragm is captured by this catheter. And the stomach is a great place to detect contraction of the diaphragm because it's so close to the diaphragm that it's very easy for it to detect the innervation of the diaphragm. And so in this picture, it shows, it can be used adults, neonates, pediatrics, but it shows this person having a catheter inserted in their esophagus, and it's in the stomach, and the signal is being brought back to the ventilator through a cable, and then there's a module that inserts on the side of the Servo Eye ventilator, and it's connected to that. The electrical activity of the diaphragm is proportional to the output of the respiratory center of the brain. Low activity for a breath that requires normal effort, and then high activity for a breath that requires extra effort. Does that make sense to you? So there's different signal strengths that come from the brainstem or the medulla. And if you're just taking a normal breath, it sends a little bit of innervation to the diaphragm. But if you want to take a deep breath, then it's going to send a stronger signal. An example of an EDI curve for a single patient breath is presented in the diagram below. The vertical green lines represent EDI signals sampled at a rate of 60 times each second. So because it's waiting for that information at so many tiny milliseconds, that makes it more accurate. So as we breathe in, the signal gets stronger and stronger, and then it diminishes as we exhale. It says a normal EDI signal is 5 microvolts. So when you're measuring the signal, those are the units of measure. So if I'm going to ask you, how is the electrical activity to the diaphragm measured? What are the units?
5 microvolts.
In microvolts, yes. And normal is 5 microvolts. So to initiate a breath, it says there's first, it says there's an EDI trigger level in microvolts. There will be an increase in the EDI signal from its lowest value, known as EDI minimum or min, and then the ventilator will initiate the breath. All right, I need to explain that to you. There's always a little bit of an electrical signal going to the diaphragm. It's not like during exhalation there's no electrical activity. There's always a little bit of activity. And we have to know how much that little bit is. It's kind of like the background noise. And we need to avoid that. We don't want to give a breath because we'd be giving all these extra breaths, and that's not inspiration. So first we have to figure out minimum activity, that normal background noise, and set the trigger above that. So once the trigger goes above that minimum noise, we know that the diaphragm is being innervated for a breath. So here it says in the diagram below, the EDI min is 0.3 microvolts. Do you see it down here? It says 0.3. That's the normal background noise, or it's called EDI min. The trigger level is 0.5, which means that the ventilator will be triggered to assist the breath at 0.8 microvolts. So far, so good? Mm-hmm. All right, so the ventilator is waiting for the trigger to be hit, but there's also a backup in case. What happens if that NG tube is displaced? Does the patient not get ventilated? So the ventilator will look for more than just the signal from the EDI catheter. It'll also initiate a breath if flow-by is sensed, the flow-by trigger or pressure trigger, as a secondary trigger source. That sounds safe, doesn't it? So once the breath is initiated, a pressure support type of breath is delivered. So Nava is just a fancy pressure support. What makes it fancy is that it's going to deliver pressure support exactly when the patient wants it.
Wow. So it synchronizes to the electrical activity, basically? That's all it's doing? Okay.
Yeah, it sees an increase in electrical activity, so it gives pressure support.
According to that?
Yeah.
Ah.
If it sees a lot of activity, it gives a lot of pressure support. A little activity, it gives a little pressure support.
Wow, that's really interesting.
Mm-hmm.
And there's no way to do that besides going invasively, like through the NG? There's no like a belt?
That's a good question. How come they can't just put a belt in the diaphragm?
That's what I'm thinking. It's invented.
Maybe.
Wouldn't that be great?
I'm not kidding.
I was waiting for the other ventilator manufacturers to come out with that soon after, because now that Nava is taking off, all the hospitals want just servo-Y ventilators so they can use Nava.
Wow.
And you would think, well, the other ventilator manufacturers should be getting in there and
Jump on the
competing with
train.
it.
Yeah.
So far, nothing. So the pressure support curve will follow the EDI signal pattern until the EDI signal has fallen to 70% of its initial value or peak value. Then pressure support will stop and the patient can exhale. So see if you can find that on the graph. We're looking for a fall in the EDI signal so that we know the patient is done breathing in. All right, so we see the signal from the diaphragm increasing, 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 kind of plateaus, and now it's starting to fall down.
Mm-hmm.
And at this point, the ventilator will stop helping with inspiration. So the amount of support given each breath depends on two things. I don't know what else to call it, so I called it things. It needs the EDI signal strength, and we have to select Nava level support. And we're going to start with 1.0. So this kind of skips a little bit. I feel like there's something more you need to know at this point. Let me go back to this picture. All right, so if we start with a Nava level of 1, and we're going to help out the patient by noticing the signal, giving some pressure support according to the signal. No, I guess there's nothing more to say. All right, let's keep going. So the EDI signal strength is measured, and if it's greater than 15 microvolts, that tells us that the patient's working really hard. So greater than 15 microvolts means a high work of breathing. Therefore, let's help the patient out. So greater than 15 microvolts indicates a high work of breathing for the patient. And we're going to want to give them more help. So that's what that first bullet says. Increase the Nava support. The more support from the ventilator, the lower the signal from the brain to the diaphragm. So if we help the patient, then the brain's not going to have to send such a strong signal. Does that make sense?
Because you're meeting the demands.
Yes. If we meet the demands, the signal will be less. So increase the Nava level by 0.2 microvolts at a time until you get your EDI signal down between 5 and 15. So we want the signal to be between 5 and 15. But what if the EDI signal is 0? Because that can happen, where you get no signal from the brain at all. And that could be because the patient is heavily sedated, that knocked out the drive to breathe. The catheter is not sensing the diaphragmatic activity. That means that the catheter came out of position. Or it could be that we're just over-ventilating the patient and they have no need for more breaths. All right, so circle that, put a star by that. You'll have to know why you're getting a 0 signal. This is showing, number 1 is a healthy patient with a normal EDI signal. It tells you in a healthy patient at rest, the work of breathing is normal. Therefore, the signal to the diaphragm is at a lower amplitude, and yet a normal tidal volume results. And looking at the patient over on the right, they have a diseased lung. So they're going to require a larger work of breathing. They're going to have to work harder to get the air in and out. The brain responds by sending a stronger signal to the diaphragm. Hence, the EDI amplitude is high, even with a normal-sized tidal volume. So, normal lung has a normal tidal volume. To get a normal tidal volume with a diseased lung, it takes a lot more work on the diaphragm's part, a lot higher signal. And yet they both have the same tidal volume. So how do you set the Nava level on the ventilator? The pressure that you're going to use, the pressure support delivered to the patient is derived from the following formula, and you have to know that formula. It's the Nava level, you're going to set that level on the ventilator, multiply that by the EDI signal, and add your PEEP, and you're going to come up with the amount of pressure support. So I have a handout, and we're going to practice with this. It's the Nava level times the EDI signal, add your PEEP, and you're going to get your pressure support level. The set Nava level reflects the amount of work of breathing that the ventilator will take over from the patient. So the higher the number, the higher the amount of help from the ventilator. So if you've got a Nava level set of 4, 5, or 7, that's a higher amount needed to help the patient get their breath. I guess that makes sense, right? The range for the Nava level is 0 to 15. Typically, you're going to see it between 1 and 4, which is normal. So write the normal range for Nava level here. Normal range for the Nava level. I guess it's so redundant because it's right above that. Okay. All right, so looking at, you touch Nava on the ventilator, and you're going to set up your Nava level, your PEEP, your FiO2, and then your EDI trigger level. You set up pressure support also in case just in case, I guess. In case you need it. And then if there's apnea, you get backup ventilation. All right, to set your initial Nava level, you press neural access on the ventilator. You'll see it over on the right. It'll say neural access right under trends. And then this screen comes up. And then you select Nava preview. And you will see, where's our, maybe it's on the next one. Looking for a gray, here we go. You're going to see an extra waveform, and it's the color of gray, and it shows how much, when the pressure support is actually being delivered, if you have Nava turned on. And you can see some asynchrony, how it looks here like the breath is beginning well after the diaphragm received its innervation. Okay, it wants you to identify the EDI signal. And then the EDI peak, and then the Nava level. So we've got pressure, we've got flow, we've got, oh, it's highlighted in red. Oh my gosh. Okay then, I'm making this really difficult for you guys here. What about EDI peak? Can you see it from where you're sitting? 15. And what is the minimum?
1.6.
1.6. So when you see 1.6 is the minimum, and you're going to set a trigger of 0.5, you add those two numbers together, and that's when the breath would start. Okay, what is your Nava level set at on this setting?
0.7.
Yes, very good. So 0.7. It's pretty low, right? What did we say is normal, 1 to 4 for the Nava level? Are we keeping the EDI between 5 and 15? The EDI signal? Is it between 5 and 15?
E-
What do you think?
The EDI signal, you said?
Mm-hmm. The EDI peak is the EDI signal.
It's at
It's at
15, so
15.
yes.
So we're keeping it between 5 and 15. And we're using a Nava level of even less than 1 to 4. So this patient probably has very minimal work of breathing. Probably doesn't need to be on the vent at this point. Do we have time? Let's see. Inserting the EDI catheter. I'll let you look at this on your own just so we can save time in class. But when you're putting the catheter in, you're looking for proper placement. In order to know if the catheter is in proper place, you're actually looking for the QRS from the heart to show up on your signals when you're putting the catheter in. You should see QRS showing up in pink colors in the second and third. And then that indicates that you've got the EDI catheter in the proper place. So I'll let you look at that on your own. What is the name of the special NG tube that has electrodes to detect diaphragmatic electrical impulses?
The EDI.
Yeah, so the EDI catheter. What does EDI stand for?
Electrical activity of the diaphragmatic,
Of the diaphragm.
of the diaphragm.
Yeah, electrical activity of the diaphragm. Name 2 settings that determine the amount of support per breath. The Nava level
The Nava level. And
times what?
EDI trigger.
The EDI signal,
EDI signal.
EDI peak is what it goes by. Yeah, so you multiply those 2 together, and that's how you find out how much pressure support is being delivered. Oh, you got to subtract the peak. But how does the Nava breath end?
when the signal starts to diminish.
Yes, so when the EDI signal begins to diminish, the breath will end. And then you could get really technical and say when it diminishes to 70% of what it was initially, but EDI signal diminishing is good. All right, is Nava a mode?
Yes.
Yeah, you could say it's a special pressure support mode, I guess, because the pressure support is being delivered in synchrony with the patient's diaphragmatic activity. So it is a pressure support mode, but
With a special feature.
with a, yeah, it's a pressure support mode with a special feature.
Yep.
I like that.
What are the indications to use Nava? Like, why isn't everybody who's on pressure support using Nava?
The discomfort of putting an NG tube in, for one.
It being so invasive.
Yeah. The cost, it's expensive.
More so than just normally ventilating
Yeah.
somebody. But wouldn't you think it'd be just the most accurate way of doing it?
Yes.
So we have to find a way to make it more accessible without being so
Yeah,
invasive.
that's true, isn't it? Why don't we have Nava on everybody so that every breath is synchronized with their breathing?
That'd be perfect.
You guys are perfect for the future because that's how you have to think. Let's get this cost down.
Let's make it easier.
Make
for
it non-invasive.
That's what I
I
was.
mean, why can't you just put a sensor right at the diaphragm and have it sense everything?
So who says who needs Nava?
Who needs Nava?
Like, if you have 2 patients both on pressure support, why would I say Daniel needs Nava and not Brandy?
Because Daniel's not coming off the ventilator, he gets really short of breath every time we try to take him off the ventilator. But Brandy is tolerating it well with her worker breathing.
Hmm.
That's what you meant initially? I'm sorry. So patients that can't be weaned, and I guess neonates. Talk
With
about
benefit?
asynchrony in neonates. Apparently, and Kim was in here, we should have asked when she was in here. Like as soon as they're put on Nava, they go to sleep because they immediately become comfortable breathing with Nava, whether they're on non-invasive through the servo-I or invasive ventilation.
Wow. So it definitely needs to be invented.
Yeah, they get really comfortable. If the EDI signal is lost, what happens?
There's a backup ventilation that'll kick in.
Yes. So we've got flow-by sensitivity that'll initiate a breath. And we've got backup pressure support set. So it goes into just pressure support ventilation. Or if there's apnea, then it'll start ventilating the patient.
There should be an apnea, something apneic set, right?
Yeah, you want to go back to it real quick? See if I can find it. Yeah, so there's backup ventilation if there's apnea, and then there's backup pressure support if the signal is lost.
Oh, so
So there's both.
you're covered in many ways.
Yes. There's a scenario, you have a patient on Nava with a Nava level of 1.0 or 1 centimeter of water per microvolt. The EDI signal was 5 microvolts, but after being placed on PRVC, rate of 20, tidal volume 500, the signal decreased to 0. Why would the signal decrease to 0? No need to breathe.
Yeah, we finished.
Too much ventilation. Yeah.
That's what she said.
So the ventilator is supplying all the ventilation, the patient doesn't need to breathe above that, so the signal went to 0. All right, next one, if the Nava level is set at 3 centimeters of water per microvolt, and the EDI signal is 12 microvolts, peak pressure less PEEP is 36 centimeters of water. What is the condition of the lungs?
Not good.
Yeah, that's pressure
If they're-
support of 36.
I'm confused. Their PEEP is 36. I mean, that's just.
No, delta P is 36.
Oh, okay.
Peak pressure less PEEP is 36.
Oh. Even then, that's still really high.
Yeah. So they're stiff.
Yeah, very stiff.
This person
lungs.
has stiff lungs.
What changes would I recommend?
Yeah, what would you recommend for this patient?
Possibly higher respiratory rate.
Yeah, so if the Nava level is between 1 and 4 centimeters water per microvolt, so that's normal, right? The EDI signal is between 5 and 15, so all of that looks normal, but yet the delta P is 36. That's a large delta P, and to have to do that once you're extubated, so we've got really good numbers. We extubate the patient, are they going to do well?
No.
If they have stiff lungs? No.
Change the mode, maybe?
To
Full support.
full support, yeah. So stiff lungs, change mode to full support. All right, so in summary, Nava is essentially pressure support with a neural trigger that gives pressure support in proportion to a neural drive.
Interesting.
All right, let me give you a handout so we can practice.
Here you go. You're welcome.
I have an extra. I have an extra.
Is she gone every time I'm handing this stuff out?
Oh, there's an extra.
All right, so it says to apply the following information to the questions that follow. For EDI, a normal range for the signal is between 5 and 15 microvolts. For the Nava level, a Nava level that indicates patient is ready to be extubated is between 0.5 and 1. If the Nava level is between 4 and 7, we can attempt to wean the patient. But if the level is higher than 7, not so good. To determine the amount of pressure support that will be delivered, it's the Nava level times the EDI peak minus min, and that's going to give us our pressure support. I think there was more added to this before, wasn't it? No. Was it minus peak also? All right, number one, the best part about Nava is that there is no asynchrony present with the ventilator breaths. The pressure support breaths begin without a delay. Pressure support breaths end when the diaphragm relaxes. On the other hand, what is a disadvantage of Nava?
So it's uncomfortable.
Expensive
Invasive.
and invasive. Number two, compare the following settings to the values listed above. Determine if the amount of Nava level support is adequate. So we have an EDI peak of 18 microvolts, an EDI min of 0.5 microvolts.
The EDI peak is.
So like 17.5.
The EDI peak is pretty high. Maybe they just need that demand.
So higher than normal.
The Nava level and the delta P seem pretty within normal ranges.
The Nava level of 1.3. Okay. And then the delta P is 23. So is that enough Nava level, 1.3?
I don't think so.
What if we turn it up? What if we turn up the Nava level to 2? What would happen to our EDI peak signal?
It'll go down.
It'll go down.
It'll go down,
Yeah.
right? So we want to up our Nava level so that our EDI peak falls between 5 and 15.
And that's also without getting the delta P too high, right, as well? Would the delta P also increase with the...
You brought up a really good point. So delta P isn't looked at as far as what should we set the Nava level at.
Okay.